ocrelizumab, sadly, the program has been withdrawn, mainly due to toxicity in infections. Epratuzumab is an anti-CD22 B-cell modulating agent. Belimumab, I'll talk about in a minute, and atacicept is another B-cell modulating agent. Abatacept is CTLA-4 Ig, I don't have time to talk about the data there. Belimumab is a monoclonal against the type 1 interferon, which is in clinical trials. We're participating in that trial. So just a word about rituximab, the anti-CD20 agent, which is present on early B cells, pre-Bs, immature, mature, and memory B cells, but and it's important to remember this, is not present on plasma cells. So plasma cells are not depleted by anti-CD20 therapy. B cells don't just produce antibodies. They can process antigens, they release cytokines, they obviously differentiate in plasma cells, but importantly, they kill the T cells. And this interaction is very, very important. So rituximab, chimeric human monoclonal anti-CD20, is a very, very efficient depleter of B cells by the mechanisms I've listed on the slide. And you'd have thought this was the key to curing lupus. Very simplistically, you say, right, here's a B cell, got CD20 on it. This paradigm produces B cells and plasma cells produce anti-DNA antibodies. If you go in with rituximab, you delete the CD20 antibodies and you get rid of the antibodies and you cure the disease. Sadly, it's not like that. This is a much more complex interaction. And we recognize that rituximab works very, very quickly indeed. We've seen benefit within a week of the first infusion. And that's clearly not because you're stopping anti-DNA antibodies, because these anti-DNA antibodies are still being produced by plasma cells which are not affected by rituximab. And we think that the rapid effect is due to deleting the cells, the B cells that are interacting with T cells. And there's some good evidence from that from Vinya Perez and colleagues in that paper. So you thought that this would be the one drug that would be a spectacular success in a randomized controlled trial. Many, many studies have shown, sort of case studies and cohort studies have shown that rituximab works. So this was the Explorer study designed to investigate whether, this is non-renal lupus, whether if you have moderate to severe lupus and you randomize patients into placebo plus steroids or rituximab plus steroids, patients got rituximab at 0 and 6 months and they were followed out to a year. Everybody stood with bated breath expecting this to be a positive study. It was not. There was absolutely no difference whatsoever in terms of the outcome measure, which was finite in this case, between the placebo and rituximab. It was really very, very frustrating. There was a slight advantage in patients with African American and Hispanic ancestry, a little bit like the mycophenolate data, but it was a negative study. Having said that, it did what it says on the tin. It actually depleted B cells extremely efficiently compared to the placebo arm, and it reduced anti-DNA antibodies significantly compared to the placebo arm, and it improved complement, both C3 and C4, significantly compared to the placebo arm. So there was definitely a biological effect, but it did not translate into a clinical benefit. Nevertheless, rituximab is still widely used. You and I will use it. We know that this drug works, despite the negative clinical trials, and these patients have long-lasting benefits. The trouble is, I don't think rituximab is going to get a license for use in lupus because of these negative studies. What about other B-cell modulating therapies? Mike Cancro authored this review. It's quite a very detailed review of BLISS, B lymphocyte stimulator in lupus in JCI. So how does this work? So how it works is that antigens, whatever the antigens are, activate monocytes, and monocytes release BLISS, B lymphocyte stimulator. BLISS is cleaved to the active soluble form, which then binds to and activates B cells, and then the B cells proliferate and differentiate into the antibody-producing plasma cells that we're familiar with, and we know that elevated BLISS levels contribute to abnormal B cell development. There's a wealth of experimental data to support that. So this is a good hypothesis of how lupus causes, or these antibodies cause trouble. So the plasma cells produce the antibodies interact with antigens, the antigen drive comes from dysfunctional apoptosis, and in the context of complement, these